All right, thank you everybody for joining us today. We are presenting the second in our Grand Round series between the justice system and psychiatry. And this is a collaborative educational series between the psychiatry departments at University of Toledo, Ohio State, and also the Attorney General's Task Force on Mental Illness and Jails. And so today, you'll be hearing from a panel of speakers, and I'm going to do a more formal introduction at the beginning of each speaker's segment. But it's myself, retired Justice Evelyn Stratton, Jeffrey Hunter, Doug Smith, and Rita Wood. So the purpose for today is three key things. I'd like to raise awareness of the CIT, this is a law enforcement training program, and also describe the role that the CIT programs would have within law enforcement and also the collaborations that they would have with the community. And lastly, how it applies to clinicians. So this is targeted towards many different types of medical students, residents, mental health clinicians. So people who are the boots on the ground with the mental health services, so that you guys are also available of aware of these resources that we have. So first thing I'm going to ask you is about what % do you think of 911 calls are about mental health crises? So think about your answer in your head, and the correct answer is actually about 10%. Now you may think that's an understatement, but remember, this is just 911 about mental health crises. A national survey of police officers found that over the length of time from starting their career to current day, overall, the quantity of calls has increased. The time spent on these calls increases also, and they're seeing a lot of revolving door type situations. And compared to other types of calls that they might get, if it's a mental health call, they take significantly longer period of time compared to larceny, even domestic dispute, and of course, traffic and other calls. So why is this important? You know, when there's a mental health crisis, law enforcement responds. However, many law enforcement officers aren't adequately trained to the extent that they, in a perfect world, would be. Also, with the laws that are currently in existence to protect civil liberties, it makes it really difficult to force people into treatment. And overall, the end result is it's a lot easier just to arrest someone when something is going on, rather than seek the appropriate help and avenues of that. So let me pose a scenario for you guys. A patient is homeless. He's non-compliant with psych meds. He's hallucinating the devil's voice and delusional that he's Jesus and he's not sleeping. And he's yelling at his mom, who he lives with. And so she calls 911 to ask for help. Now, this is not unusual, right? And so depending if you're on the law enforcement side or you're on the clinician side, we might handle this two very different ways. And one of the things that we talked about for their first Grand Round series was about mental health courts, and how that can definitely make an impact so we don't just incarcerate the mentally ill. But so today's topic is on the CIT portion, and mom makes that 911 call. What happens then? So if we take a step back and understand, well, what does it take actually to become a police officer? What kind of training do they get before they enter real world and have to respond to these calls? So what you see listed here is a checklist, different aspects of physical abilities. You have to take the civil service exam, and that's for any kind of job that you would want to have working for the government. CIA, FBI, Secret Service, any of these things, they have to all take the civil service exam. So how much training about crisis intervention is mandated during Peace Officer Academy training in Ohio? Now, take a guess in your head, and the answer is 24. And I'm going to go through this step by step a little bit more. What you see listed here is a checklist of all the required trainings, and 24 out of the total 737 hours is required for crisis intervention. And that's only as of 2019. The data from 1999 was 6 hours. 2013, it went to 16. 2016, it went to 20, and now it's 24. Now, one of the big differences between what is mandated through the normal training for police officers versus CIT is this is for law enforcement by law enforcement. And it's implied that they're going to cover mental illnesses, suicide prevention, versus CIT, which we'll talk about, but it's an extremely comprehensive program taught by the experts in the field. Overall, this is a significant problem with law enforcement and mental illness and that intersection on the streets. And about 1/4 of individuals who were fatally shot by police were those that had mental illness. And if we look at models of policing across the nation for crisis intervention, there's 3 general types. One is a police-based specialized response. One is police-based specialized mental health response. So sometimes you may see things in the media across the nation about, oh, this sheriff's department has paired with a case management team and they both go out tandem, those sorts of things. And the last one is a mental health-based specialized response. So these are the 3 different models of crisis intervention, in which CIT is more on the left there. So this is, you know, a problem in general. We are all generally, you know, we live our lives, we do our thing, we're on our own little bubbles. And statistically, about 1 in 50 individuals with untreated severe mental illness, that's what SMI stands for, it's about 1 in 50 US adults. So that's only about 2% of the population. However, those individuals are 1 in 4 police shootings, 1 in 2 fatal police shootings, about 1 in 10 calls for police services, 1 in 5 use of prison and jail beds, and about 1 in 3 are transported to the emergency room by police. So a small subset of the population ends up having a lot of significant adverse outcomes. And one other thing to consider is, you know, over the past few years, there's been a lot more light shed on racial disparities. So consider this. So in general, African Americans are nearly 3 times more likely to be killed by police than white Americans. And if you layer the racial disparity in diagnosing mental illnesses on top of that, in general, Black Americans are diagnosed 2 to 4 times more often with schizophrenia than white Americans, even with the same criteria and presentation. So it becomes a potentially fatal event when police are called to intervene on Blacks in America with a mental illness without appropriate training and resources. So how did CIT start? So this is a grassroots initiative, which meant all it took was 1 person to get this nationwide movement off the ground. In 1986, a lady named Ann Dino, her son Bubba, was transported to the hospital in a police car because he had a mental illness and the ambulance wouldn't take him. And at that time, she was president of NAMI Memphis, and she met with the mayor and said, hey, how would you like to read the headline tomorrow? Mentally ill man bleeds out in the back of a squad car. And another board member at the time, Helen Adamo, had her own story and said, the first time I called the police for my son, they came in with their hands on their guns and their billy clubs, and they didn't know what to do. So they wrote a proposal for the mayor and the city council to support training for police officers in responding to people with mental illness. And this was based on a model done by the LA police that one was focused on the need to reduce the injuries to the police officers responding to mental health calls. And then, of course, like nothing really happened. It was slow going. The following year, September 24th, 1987, the mother of Joseph Robinson called 911 to report that her son, who had a history of mental illness and substance use, had been cutting himself with a knife, threatening suicide and threatening people. And so police encountered Joseph Robinson on the street outside of his mom's house. And according to police, he did not respond to verbal requests and lunged at the officers, who shot him multiple times, and he died. Community organizers, civil administrators, University of Memphis and Tennessee, and the Memphis Police Department, they all then came together to organize CIT. And the very first CIT training was in 1988. So now you know a little bit about how it came to be, but what is it? So there's some flexibility among the different programs that are put on by the counties, but in general, it's a very comprehensive training that takes an entire week with a combination of classroom visits, site visits, and role plays. And it involves local experts and also family members of those with mental illness, brings in NAMI panels, and often you can get a sneak peek into your local data of what's going on live in your community. And there's initial courses and then refresher courses. And here's an important thing is that it's free to do. And it's voluntary, which I think is very important also. And these, what you see listed here, are some of the examples of the topics that are covered in the curricula and programming of the week. And again, there may be some differences in each unique program, but it's been around for a long time. And what we know is that it works. It increases safety, knowledge, resource knowledge, and also crisis intervention skills knowledge. And overall, it results in decreased costs to all of the systems involved, which is a win-win. So what is it not? Well, it doesn't turn law enforcement into social workers or psychiatrists or therapists. It doesn't give or excuse any sort of criminal behavior. And it's not for every law enforcement officer. So when you go through the training, that already means that you have a special mindset to do this. And so if you're called to action as a law enforcement, then you are a super specialist. And it's also not a quick fix. Obviously, this is one piece of the puzzle. So my introduction is completed. Now I'm going to introduce our first speaker. Justice Evelyn Lundberg Stratton served for 16 years as a justice on the Supreme Court of Ohio and for 7 years as a trial judge, and is currently retired. She has worked for decades in both Ohio and nationally on issues involving those with mental illness in the criminal justice system. She established the Supreme Court of Ohio Advisory Committee on Mental Illness and the courts, which then merged into the Attorney General's Task Force on Criminal Justice and Mental Illness, serving for 8 years as co-chair with the former Attorney General DeWine, and which she now will continue as co-chair Attorney General Yost. She serves on Governor DeWine's Recovery Ohio Advisory Council, which advises him on addiction and mental health policy issues, and also heads the Ohio Stepping Up project. She has worked both nationally and in Ohio on setting up veterans treatment courts and veterans justice outreach specialists. In addition, she founded Operation Legal Help Ohio, a nonprofit which connects veterans and military families to a statewide system of referrals to pro bono lawyers, bar associations, legal aid, and law school clinics. And in her spare time, she does also appellate coaching and mediations through the Voice Law Firm. So introducing Justice Stratton. Justice Stratton, are you available?
Here I am yakking away and not muted.
Okay, here we go.
Thank you. I would like to give you a little bit of background on how I got into this work, because that's not a usual function role for a justice. I was a missionary kid, born and raised in Thailand, went to boarding school in South Vietnam and Malaysia, came to America when I was 18. Never really saw mental illness growing up in the mission field because the families were very intact. Didn't really see it in college, but when I was elected a trial judge, I saw it front and center. So many people in my court had mental illness, often co-occurring diseases with drug and alcohol, and the system was fragmented and nobody talked to each other. And as I kind of progressed through my trial stages and then got to the Ohio Supreme Court, I started learning about mental health courts, which was the subject of our last presentation, and how it was a way to try to get at the cause of a person being there and give them tools and support to keep them from coming back. And at the same time, I learned about CIT, which at that time in Ohio only had about 100 people. And I became convinced that this was a much better solution to deal with people that I saw when I was a trial judge. And that's when I put together my first committee. One of the advantages you have as a judge is you campaign. And I gave hundreds and hundreds of speeches. And I decided to limit almost all my speeches to mostly, even if I had to talk political campaign stuff, about getting me elected, I talked about mental health courts and CIT everywhere we went. And you have lots of opportunities to have a bully pulpit. So as Dr. Hunter will tell you, we now have almost 13,000 officers in every county. So we've made some changes. So next slide, please. I now head Stepping Up Ohio, which is a project to work on trying to change the paradigm of mental health, of jails being the mental health de facto hospital. Prisons and jails have the highest percentage of mental illness, more than our hospitals do. And these are some quick facts that you can look at, because you all have those slides, to see the number of people in our systems. And that's the sheriffs said, we need help. They went to the county commissioners and they got this project going. And so we're trying to work on changing that paradigm. Next slide, please. So this is just a description of the project. I'm not going to read it, but what we do is we do lots of things in all the different counties to try to reverse the cycle of mental illness and criminal justice and try to get them intervention earlier and treatment earlier. And CIT is an absolutely crucial piece of this. Next slide, please. So the importance, these are just ways you can help your counties join. So next slide, please. So one of the things I did was put together the committee at the court, and then I joined Attorney General DeWine and now Yost to put together this task force. And the reason I want to share this with you is you as students can get involved right now. You don't have to wait till you graduate. You can start looking at things you might want to be interested. The task force is a wonderful place to get involved. There's 500 members. Anyone can be a member. At the bottom, Carolyn Bevins is how you join. You can join any of these committees. If you're interested in housing, you're interested in juvenile, law enforcement, psychiatry and treatment, which is the committee that puts this program on, you can join and get involved right now because it's very important. When I was a judge, the medical community wasn't really very engaged with criminal justice. And I kept pushing and pushing and trying to get them more engaged. And now I'm on the National American Psychiatric Association Foundation and continuing to push because there is a huge population in our jails and prisons that need help, need treatment, need advocates, need someone who understands their issues. And you as psychiatry students and you as medical students are at the center of all of it in terms of providing that assistance, that guidance, that training, that advocacy. And that's why it's just so important for all of you to do that. Because what happens is when a police officer gets trained in CIT, they learn about all the systems. They learn about treatment. They learn about where they can drop them off instead of taking them to jail. And in some ways, that's a problem we created. We don't have enough places to take them now instead of jail. So we're working on that in a whole statewide program called a Crisis Continuum. But those CIT officers often now understand what a mental health facility is. And I've had so many officers tell me, I didn't have any understanding of what that person was going through. I didn't understand mental illness. I thought they were just acting out, not cooperative. And now I went and personally visited the mental health facility. I went and personally visited the treatment facility, introduced myself and said, I'm a CIT officer. I'm here to help. So you as students getting into the profession can serve so many different roles to be that advocate, be that connector, go down and introduce yourselves to your mental health courts, your drug courts, your veterans courts in the county that you end up in, or wherever you go in the country, because this movement has spread all across the country, and become a person who's really involved, because we really need to change the paradigm of jails being the de facto mental health hospital. We need to reduce the need for mental health courts, because if we can get to them sooner, get them stabilized and get them resources, we can really make a difference. And so that's one of the reasons when I was on the Supreme Court, I approached OSU to ask about doing some introduction on mental health courts, and that started the grand rounds. And then the program is no longer done at the Supreme Court. So we, through the Attorney General Task Force, decided to take it up. And that's resulted in the first program on basically what is a mental health court and mental health in the system, criminal justice system, and now this one on CIT. So we've got a great panel of speakers who are real experts in the field. Please reach out to any of them, join the task force, get involved. It's not any too early to start becoming an involved person in making a system change. I just want to say there's a lot of talk about defunding the police and mental health issues and that. Ohio is so far ahead of the curve because we did this long ago, where we had our police officers become trained. Many of our counties now have mental health specialists that ride along. They're trying to develop other ways to approach a call if it doesn't involve violence that requires a police officer. So we are a firm believer that we need to get to the root of the problem, and we've been doing this long before it became popular.
Cops in our state that have killed people.
Who is Dr. Wood is not muted. And that brings me to the end of my presentation. I wanted to leave plenty of time for our wonderful experts to talk about what they do. And one of the my favorites is Dr. Hunter, who I've known for many years, has been involved in just about every committee I've done since I got on the Supreme Court. And I'm so excited to have him come and present because he has a very unique perspective, which he will tell you about as a physician.
Thank you so much, Justice Stratton. All right, so next up is Dr. Hunter. He is the Chief Quality and Safety Officer and a Senior Vice President at Concerto Care. He's an experienced physician, educator, law enforcement officer, and healthcare executive, and he has extensive experience in quality improvement, electronic health records, patient safety, coding and compliance, healthcare privacy, peer review, risk management, systems improvement, and last but not least, medical education. And his experience as a physician and also a physician executive spans both private and public sectors. He has over 20 years experience as a police officer and deputy sheriff, and most of his law enforcement career has been spent as a detective and a police trainer. And he's certified in CIT and teaches trauma-informed policing, and is also a certified trauma counselor for law enforcement. He received his Bachelor of Science and Master of Science from Ohio State, Doctor of Chiropractic from Logan College in St. Louis, and Doctor of Osteopathic Medicine from Ohio University. He completed his family medicine residency at Grant Medical Center in Columbus and has additional specializations in hospice and palliative medicine, sports chiropractic medicine, and acupuncture. Dr. Hunter also served as an assistant dean at the OU Heritage College of Osteopathic Medicine and as the chief of the Geriatrics, Rehab Medicine, and Academic Affairs Department at the VA Chillicothe. He is also a clinical professor at the Ohio University Heritage College of Osteopathic Medicine. So welcome, Dr. Hunter.
Well, thank you very much, Dr. Kelly. I often get asked the question, oh great, my screen just went blank. Well, I can do this off paper. Can you still hear me?
Yes.
Okay. I often get asked, why, how is it you became a police officer and a physician? And my easy answer is, well, ever since I can remember, I always wanted to be a doc and a cop. So I didn't see any reason why I couldn't do both. I really have enjoyed my law enforcement experience because I've been able to find that many police officers, of course, they want to do the right thing. And it's just a matter of understanding when it comes to persons with mental illness, what they're dealing with. And the CIT program is just excellent in helping provide officers with that specialized training. I also serve as the co-chair of the Psychiatry and Treatment Committee of the Attorney General's Task Force on Criminal Justice and Mental Illness, along with Dr. Joy Stankowski. I wanted to give a shout out to her as well. Next slide. Ohio and CIT. CIT is in all 88 counties across Ohio. That's 697 law enforcement agencies. And I believe in Ohio, we have shy of 900 law enforcement agencies. 12,000, that's almost 13,000 officers have been CIT trained in Ohio. We have, I'll just round off to maybe 27,000 law enforcement officers in the state of Ohio. So you can see that is a hefty percentage. And just in Lucas County, you can see that 1,111 individuals completed CIT training since 2001. Now, this was no easy task. Ohio, as you know, it's a mixture. It's a mixture of urban, suburban, and some very rural counties. A lot of these law enforcement agencies are small, A lot of them are volunteer only. A lot of them are staffed with part-time officers. So while the training is free, the cost of paying the officer to attend isn't free. And that was causing a lot of problems. And thank goodness NAMI is one of the organizations that stepped up to the plate in providing many grants to help offset that that overtime or the money they had to pay to get coverage so that officers could attend. Next slide, please. Now you can see on this map the historic crisis intervention team training information. And this is for full-time Ohio peace officers only. I'm not going to read the whole thing to you. You can study that, but you can see that the vast majority of counties do have over 21% equivalents of their officers trained since 2000. And like we said, all 88 counties are covered. Next slide, please. And this is something else where I gave you the number before, but 76% of law enforcement agencies participate in a county or multi-county CIT program in Ohio. And you can see there, again, I won't read the numbers, but it gives you the stats, and there's the legend off to the right. And next slide, please. And this I'll just make a quick mention of, and that is that the Ohio CIT project, what this does is also hope to extend CIT type training to medics, to parole officers, obviously corrections officers, all sorts of first responders or people in the front line that would encounter somebody with mental illness in a crisis. And so this is expanding beyond just law enforcement. Next slide. And this is how to interface with local CIT programs. Reach out to the local CIT program coordinator. The coordinator can be a law enforcement officer, but it's not unusual that it might be somebody associated with the local ATOM board, for example, something along those lines. And you can learn more about their CIT program. Consider attending a CIT BH professionals training. And then what they would really love is if you reach out to that CIT coordinator and discuss presenting an area of expertise of which you have and you're going to have. And I realize you're residents, but talk to your RPD and see if this is something that might even be able to be done now. I know the RPDs are probably going to hold me at the stake after having said this, but really, even you know, input from residents. I know we have that on our AG task force, and it's very, very helpful. Also, assist CIT program with connecting them with resources and points of contact in your service area. That is one of the big things that CIT does. While the national and state guidelines on the program, there are also, it's very local. You know, what's available in Columbus may not be available in, say, Putnam County. That is something that's really important for the officers to know. They think they may know, or they may not know at all. And even the program coordinator may think that they know, but if you can help even say, you know, have you, do you know about this? Or have you connected with this person? that's the type of networking that really gets us to be even more effective. The next area is one that's extremely important to me. Provide feedback to your local CIT program when you become aware of a client or their family interacting with law enforcement. I've had personal experience with this, and all I can say is advocate, advocate, advocate. These are your patients. These are folks that if you can intervene in any way and help with the law enforcement, even with the prosecutors, the court, and be able to say, I do want to, by history and from what I can hear of the incident, whatever it was that brought them in contact with law enforcement, that occurred, based on what I've heard and gleaned, I feel this person was in a psychotic crisis. They were in a mental health crisis, and that, I think, especially it depends on the locality, will go a long way. That this really wasn't criminal activity per se, but this person really believes that they heard or saw, or their delusion was, and that's very important. It's very helpful. It also helps educate the local law enforcement apparatus and system. And then, of course, invite CIT officers or coordinators to speak at any events you may have. This is something they love to do. And guess what? When they're addressing a group of docs, just based on the questions, they learn a lot too. And it also lets them know the importance of what they do. So I'll just wrap up by saying, with all my years as, teaching in residency programs, practicing, also as a law enforcement officer, I think everybody certainly wants to do the right thing. It's just a matter of, have they been trained to do so? And in that training, have they been able to exercise it? It could be that, shoot, in Columbus, you get all of the officers in police academy get the full 40-hour CIT program. Is not required by the state, but the city requires it. In Franklin County, where Columbus is located, the sheriff's deputies get the full 40 hours once they're out in their field training. Again, that's something the sheriff has decided to do. But in a more rural county, they may not be able to have as much experience in exercising what they've learned. And that reinforcement, if you're able to in any way interact, I think is very much appreciated. Even if you want to give a guest lecture, to which I've done, to a local law enforcement agency, and sometimes I've done it where they're working 3 shifts, and I'll space it out over time, and I'll hit every one of those 3 shifts so that I can at least provide 45 minutes, an hour, where I can talk to them and reinforce the importance of the concepts of CIT. So with that, I will pass it back to Dr. Kelly. Sorry for the technical difficulties, but I'll be interested in any questions you may have. Thank you very much for the opportunity.
Thank you, Dr. Hunter. And again, for everyone, if you have any questions, please write them in the chat box, or you can message me directly, and we'll make sure at the end we reserve a few minutes for questions. So next up is Dr. Smith. Dr. Doug Smith completed his medical degree at the University of Maryland School of Medicine, his residency in psychiatry at the Shepherd and Enoch Pratt Hospital in Baltimore, and fellowship in forensic psychiatry through a combined program at the University of Maryland School of Medicine and Johns Hopkins School of Medicine. For over 10 years, he served in the role of medical director for 3 North Coast behavioral healthcare inpatient and 3 outpatient sites until 2012. And since then, he has served as the medical director for the Summit County Alcohol, Drug Addiction, and Mental Health Services Board. For those students who don't know, if you hear ADAM or ADAMS or Mental Health Board, that's what that means. Every county has one. During the past 23 years in Ohio, Dr. Smith has been involved academically, serving as Clinical Associate Professor of Psychiatry at the University of Toledo, at the UH Case School of Medicine, and at Northeast Ohio Medical University, where he is a full professor of psychiatry, the director of community psychiatry, and the medical director of the ECHO Super Hub, and co-director of the Integrated Community Psychiatry and Primary Care Fellowship. He has lectured literally across the world, co-authored more than 20 publications, and in his spare time, he also has a part-time forensic psychiatric practice. And he's continued to be active at the state level for many years, including serving as a member of the Board of Trustees of NAMI Ohio and the Ohio Health Information Partnership, and also involved with Ohio Psychiatric Physicians Association. So welcome, Dr. Smith.
Thank you. And even with that, I don't sound nearly as busy as Dr. Hunter. So after that introduction, thank you, Dr. Kelly and Justice Stratton and Dr. Hunter. So I'm going to talk real briefly, because I want to leave time for some questions about CIT and really also about jail diversion, which is part of why we think CIT is so beneficial. Next. So this is really the biggest problem coming from the premise that Justice Stratton started with, that we have way too many people locked up in the United States. We are land of the free, right? But for some reason, we actually tend to incarcerate more individuals per capita than many other countries in the world. And so we need to figure this out. And what that translates to is that we have more people with psychiatric disorders in jails and prisons in this state as well as across the country than we have in state psychiatric hospitals, such as where I used to work at North Coast Behavioral Health Care. So that's a real problem. And in fact, it's hard to do this interactive, so I'll just say it. The 3 largest psychiatric institutions in the country are the LA County Jail, the Cook County Jail in Illinois, and Rikers Island in New York. That is prisons, not actually state or federal psychiatric hospitals. So that tells you we have a problem. So part of the premise of CIT is that it fits into the sequential intercept map created by Dr. Mark Munitz and Dr. Patty Griffin from NeoMed, and I apologize, I forget where Dr. Griffin was from or is from, but they created the sequential intercept map, and we've applied it across the state. Again, you can look at the NeoMed Criminal Justice CCOE website to learn more about that. We've done it several times, twice actually in Summit County for criminal justice mental health, and once for the opiate epidemic, actually, to look at what happens prior to anybody ending up in jail and what happens after they leave the jail to help prevent them from returning to jail. That's the very simple version of what otherwise could be its own 1 hour or more talk. So next slide. And so you'll see then, apart from who is already incarcerated, of course, there are a lot of people who come out of incarceration on either probation coming out of a jail or parole coming out of a prison. Those are what the 2 terms refer to. And the net result is that we therefore have a lot of individuals with mental illness who are being touched by the criminal justice system. And the T in CIT, as Dr. Hunter said, is team. And the idea here is we want to create a team that includes clinicians, law enforcement of all types, as well as the judges, as well as paramedics, as well as dispatchers, as well as all the clinicians in the outpatient settings and on occasion the inpatient settings. So as a team, we're working better together. And so when we teach CIT in Summit County, we actually just had one of our classes a couple of weeks ago, the 40-hour class. We start off by indicating that, number one, it's an officer safety class. And you heard Dr. Hunter allude to that with the original Memphis model. So our goal is that we're trying to make sure that these officers go home safely at the end of each day. And again, paramedics and so forth are also in our classes. And at the same time, we want the citizens to have a safe transport to wherever they're going, or perhaps safely stay at their home, depending on the various crisis intervention models that Dr. Kelly described. Next. So again, you'll see here a simple version. You'll see different studies will give you slightly different numbers here, but basically the severe mental disorders are about 2.5% in the general population. Serious mental disorders, 5%. And then so the severe mental disorders tends to be the smaller circle, schizophrenia and similar illnesses and bipolar disorders. So that tends to be that about 1% is schizophrenia in our population, about 1.5%, rounding it a bit, is bipolar disorder. Serious mental disorders adds to that with serious major depression, perhaps borderline personality disorders, et cetera. And then, of course, all the diagnosable mental disorders end up to be at about 16%. Next. So what happens in the jails and prisons? It's higher than that. And that's a real problem. So individuals, of course, and you heard the original example in Memphis, you have an individual, if an officer is trained in the usual command presence in his or her uniform, expecting people to obey orders. And remember, we've all grown up long before any of us developed mental illness. We have all grown up with the concept of authority. We know that people in uniform have authority. We know that judges in black robes have authority. We tend to know early on in life that we should respect those authorities. So when you have a mental illness, although you don't lose that thought, you may, of course, be hearing another voice. You may be seeing someone who's not there. You may not be cognitively intact. And the net result is you don't necessarily have the capacity to obey the officer in front of you. And that may be taken by an untrained officer, not trained in CIT, as disobeying an order. And that can lead to an escalation. And that's not the goal. That means the officer can get hurt and so can the citizen. And you'll see the net result is those individuals get into interactions with officers and end up in jails and prisons. So what could have been a disorderly conduct call for an officer, let's say I'm the officer, I show up, the person doesn't comply, I end up going hands-on, I take the person, guess what? Now they're resisting arrest. Maybe they punched me in the process. Now they're assaulting an officer. Now it's a serious crime. It went from what could have been a minor misdemeanor to a very serious felony charge. Hitting an officer is a serious crime. And now they end up in a jail and possibly prison. So that gives you a simple snapshot as to how these individuals end up more in those institutions than in our psychiatric facilities. Next. So here's some basic numbers. You'll see these are a little bit delayed because we don't get the numbers as fast as we want, but I've got it up through 2021. So you'll see the number of hospital beds for the Department of Mental Health and Addiction Services, a little bit over 1,000, but notice that a lot of them are forensic. That is, they've been found not guilty by reason of insanity. Or they're there for incompetent to stand trial or for evaluations. There is a movement now to do outpatient competency restoration around the state. That's relatively recent, trying to decrease that population so there's more availability for civil patients to go into those hospitals. But be that as it may, those number of psychiatric beds pale by comparison to the number of inmates in Ohio prisons. And ODRC has really worked hard to try to partner, including with OMAS, to try to get individuals to not end up in the prisons and also to get out sooner and move forward with care in the community through the Linkage Project. So despite all those efforts, we still see this large overrepresentation in prisons versus psychiatric hospitals. Next. So diversion is this effective way of doing business for criminal justice, mental health, consumers, and their families. So all of these groups plus others are part of the team. When we do the CIT course in Summit County and many across the state, we have NAMI family members come talk to the officers and paramedics. We have consumers who are doing well enough in their recovery to come give a conversation, excuse me, with our first responders to build empathy so that they have a better snapshot of what's going on behind the scenes before they're called to the house. And that makes a big difference in terms of the interactions that then take place more safely. Next. This is the only slide that's on the quiz. I'm kidding. But this just shows you this, just really a reminder for the sequential intercept model, which again is a subject for another talk, so we can move on to the next one. And here's intercept one. That's what we're really looking at here today, is what happens in this first intercept. Again, I get called to the scene as the officer. Mr. Jones is not behaving appropriately, whatever that means. I'm using that broad term on purpose. I need to make an assessment. If I'm a CIT officer, I may be better equipped to realize maybe there's a psychosis going on. We don't turn officers or paramedics into diagnosticians. We try to add to their ability as a trained observer. In fact, when I teach my portion of the class, I say that they are similar to me. Dr. Hunter embodies both of them, are trained observers, right? We are observers of human behavior, what comes out in terms of their speech, how are they behaving, how are they thinking, how are they acting? And that is really where we are all similar as part of the team. And then we try to decrease the likelihood of an arrest when an arrest is not appropriate so that we can get them into care. A lot of challenges, right? So 7 to 14%, depending on the study. Dr. Kelly made it simpler for you. 10% of these law enforcement encounters tend to involve individuals with mental illness. Many places before CIT had no idea what the officers, where do I take them other than jail? So they all went to jail. So this CIT movement, which again is in all 88 counties now, which is phenomenal for any state in the country. We literally, I think, are the most trained in the country. But there is now a CIT international group nationally, and you're welcome to look at those meetings to attend. I believe the one coming up is in Pittsburgh, so not too far afield if you're interested in learning more. Next. The specialized crisis sites, right? So where do we take people? So law enforcement and part of this whole crisis continuum that Justice Stratton started to talk about is so officers need to have tools on their belt, which in this case, we're adding verbal skills and recognition of mental illnesses to their belt and sometimes substance use situations. And then they need to have a safe place to take the person apart from a jail. So that is part of your crisis system. And again, I'm happy offline to talk to individuals about the Summit County system. We're fairly well resourced, although there are still gaps that we're working on, but I'm happy to talk to people about that offline or during the question and answer session. You've heard about this, so we can move forward. You've already heard what CIT is nicely from Dr. Hunter. Again, just a reminder that where we are, here it is. It's way more than training. The point of this is it is a team of many, many people, including consumers, including NAMI and their family members. Full disclosure, you've heard that I'm on the NAMI board of trustees, so I'm very much involved in this. I think this is clearly a key amongst many other programs that NAMI provides. And then you've got judges, you've got prosecutors. We have a criminal justice mental health forum in Summit County, which is now called Stepping Up, which Justice Stratton leads for the state. And that is where CIT rests now, so that we can talk to many, many people on the team on a regular basis about how to enhance the CIT training, because it's way more than training. It's all those interactions. With that, I'll stop for the next one. There's my contact information if we don't cover enough in the questions and answers. Thank you.
Thank you, Dr. Smith. Next up is Dr. Rita Wood. She works with the Department of Veterans Affairs, VA Sierra Pacific Network, and is a staff psychologist there. She's also involved on the state and national level with Ohio Psychological Association and the American Psychological Association, and participates with the Ohio Attorney General's Task Force for Veterans Courts and Military Affairs Committee. So Dr. Wood.
Thank you so much, Dr. Kelly. You can move forward, please. Everyone can see the objectives and read them themselves. Next one, please. So what I want to point out here is that Ohio has over 866,000 veterans in our state. And a lot of these veterans are the OEF veterans who have come back, and it's been the longest sustained military operation. And those veterans have oftentimes been deployed multiple times. And as you can see, 60% of the 77% of veterans who are deployed post 9/11 served on 3 or more deployments. And that means they were more likely to see combat, more likely to sustain injuries, and more likely to see some of their fellow veterans killed while in action. Next slide, please. So these are some of the specific health issues that veterans often encounter. I won't read through them for you, but I'll give you an example of a veteran, a young OEF veteran that I had, who had post-traumatic stress disorder. He had traumatic brain injury and chronic pain. His envoy was attacked, and he saw some of his fellow veterans killed. And because of the IED, he sustained the traumatic brain injury, and he had chronic pain and had to use a cane after that. And so having those injuries and having to deal with that on a day-to-day basis as a mid-20-something veteran was not easy for him. So he had a lot of issues with interacting with other people. He had problems with relationships, domestic violence, which also led to some legal issues. And veterans often have legal issues because of the marital conflicts. Their domestic violence, interpersonal violence is very common. Substance abuse is very common. When they're suicidal, the police often get called. And so there is a lot of interactions with local law enforcement, and them knowing that they're veterans and what they possibly could have gone through helps in those interactions in de-escalating. Next slide, please. So knowing these statistics and knowing that there's been a lot of veterans who have incurred trauma and may have a lot of those injuries, sustained injuries, the hidden injuries with the mental health issues is very important. And a lot of our police officers are veterans themselves. And so they can relate and understand what veterans they encounter when they go out on a call may have gone through. Next slide, please. The other thing that's not as common, but is coming to light, is military sexual trauma. So a lot of our veterans, not only women, but men, have experienced military sexual trauma. And this is of the people who have reported it. And so there is a huge distrust of other people. And sometimes it's been commanding officers who have committed those assaults. And so they don't trust police officers. They don't trust people who are in positions of power over them. And so understanding that is extremely important too, and educating CIT officers about those things are important, because they may, if they try to go at them as, you're a soldier, you must listen to me, you must obey and do as I say, that might not go over well if they experience military sexual trauma at the hands of a commanding officer. Next, please. And so Dr. Kelly earlier had talked about the Memphis model and how CIT started. And so that the VA was a part of that at the very beginning. So the community, they understood, the mayor of Memphis understood that veterans should also be a part of the conversation, and how do police officers interact with them. And then I found this wonderful quote from the FBI Law Enforcement Bulletin: "No one crosses a river without getting wet, and no one goes to war without being changed." Knowing that and understanding that is very important. It changes your life perspective when you have been engaged in war. You see the ugliest parts of humanity, and you don't see the good parts of humanity. And so a CIT officer, a negotiator, understanding that is the best hope for a veteran. And that's also true for someone with mental illness. Someone who understands what's going on or may be going on with the person is the best hope that that individual has. I know I went through this very quickly, but we're running out of time, and we wanted to leave time for questions in the chat.
Thank you so much, Dr. Webb. All right, just a few minutes of closing, and then we'll open it up the last 5 minutes. So I am Victoria Kelly, Dr. Kelly. I'm a psychiatrist. I lived in Ohio my entire life, and I actually became involved with the CIT program when I was a resident. And I was starting out just as the role play. And let me tell you, it was fantastic to channel all of my acting skills and anchor to be a manic psychotic patient for these law enforcement to practice their skills on. So my angle is education. I'm all about educating. It's why I go on the news and do things there to help educate, so that in the end, ultimately, our patients benefit. so whoever can hear the message. So why should we care? Going back to that scenario in the beginning, this guy's homeless, non-compliant, right, hallucinating, delusional, yelling at mom, and she calls 911. Now that's the CIT version. So why should students care? Well, because they're going to be calling your clinic. They're going to be calling the front desk. They're going to be showing up to the ER. So you have to also know what resources are there in the community, what to tell them on the phone. What do you tell mom? Let's say mom's your patient and she's calling you, freaking out, asking for advice. You have to know what's going on. Another thing is what we lovingly call the Swiss cheese model of morbidity and mortality and poor outcomes. It's a principle of layered security. For a bad outcome, there's a lot of bad things that have to line up just right for everything to slip through the cracks and have that bad outcome. So being involved with the CIT helps perhaps with one slice of that Swiss cheese. And as a student, a resident, a psychiatrist, a whatever kind of clinician you are your own individual slices of cheese. So, have accountability and to do the best that you can with that. So, when you're talking with loved ones of those who have severe and persistent mental illness, prevention is really key. They need to know what's going on and how to be supportive. When should they be reaching out? So that hopefully they never end up having to call 911. But they need to know what's the emergency resources there. And anything you can do to prevent a bad outcome is way better than having to deal with the aftermath of something after a bad outcome. So when you are advising someone about a crisis, the personal safety is priority one. So if you're talking to mom on the phone and she's going through the scenario, she needs to be safe, number one. When law enforcement come on the scene, one of the first things they're going to do is restrict access to lethal means. That means no guns, no knives, no, get the pills and alcohol bottles out of the way. Any information that they can convey to law enforcement about the patient's diagnosis, medications, history, where do they get treatment? There's many ACT, assertive community treatment teams all across Ohio. And there's 24-hour hotlines, on-call services. So there's ways to get information to law enforcement that can be very helpful for them. Also, very important is tell mom, if you ever need to call 911, ask them to send a CIT trained officer. And if they have one, of course, they'll do it anyway, but it never hurts to ask. So that is the end of our talk here. We have a few minutes left. I thank you all for listening intently. We had 3 questions that had come up, so I was going to answer those and bring them to the panel. And after that, we can open it to the floor. So one question was, is it just law enforcement that attends these trainings? And the short answer is no. We have hospital security, university police, and even EMS. So often what has been found is that it's been so well received that everybody wants a piece of it. So they end up offering additional trainings in the same model of education. And so that was one question. Another question was if it was all geared towards adults. And no, the answer is no. They do also crisis management and site visits and things like that for children, the intellectual disability population, and so it definitely includes children and child resources also. Another question that had come up was about the how long lasting the impact was. So we have a bunch of data that I had briefly skimmed over saying how great it was for safety, and actually helps a lot with stigma and comfort levels of dealing with mental health crisis. But what is the long-lasting impact? Does compliance with CIT methods persist? So you do the training and then you're great because it's all fresh in your mind, but what happens a little bit later down the road? We do have refresher courses, but I'm going to open that question up to the panel if anybody had any insight. Dr. Wood, Dr. Hunter, Dr. Smith, Justice Stratton.
This is Justice Stratton. I think that there are very much long-lasting effects because what they get then is field experience. They go and they respond to these calls and they see in action how their de-escalation techniques work, how effective they are. They learn through practice and trial and error how to be even more effective and better at it. We also offer advanced CIT training courses. one particularly on veterans and other issues so that they can continue to get advanced training. But what I have observed is I think they just get better and better as CIT officers.
I'd also add that of course, there are agencies, like I said, Columbus Police, Franklin County Sheriff's Department, where everybody gets trained. But in many of the agencies, it is voluntary, and it tends to be the officers that, you know, they see the need and they're seeking that training. So for them, it gives them an insight that doesn't leave them. They see that and they realize, wow, you know, I look at things in a different way now. So and plus on top of everything that Justice Stratton just mentioned.
Right. Well, thank you everybody for attending. This seminar has been recorded, so if you have any requests for it, just let us know. Our contact information is included in the flyer. And stay tuned for our third series coming up. We'll let you know when that comes. And we'll be talking about more topics pertaining to the intersection of law and mental illness. Take care, guys. Bye.